Hello, and thank you for coming. My name is Rachel, and I'm a Master of Public Health student at Columbia. Today, I'll outline why we should continue the 1800-year-old practice of fighting tuberculosis, or TB, with food, especially given that COVID-19 has reversed a decade's worth of progress and limited our usual tools for addressing it. I'd like to start with a brief overview of TB. This is a respiratory infectious disease that's spread by coughing, sneezing, or otherwise expelling bacteria into the air. Hallmark symptoms include violent coughing, dramatic weight loss, and fever, and kills by filling one's lungs with fluid until they drown. Until November 2020, when it was surpassed by COVID, TB was the world's leading infectious disease killer and continues to take 3 lives every minute. Each year, 1.5 million people are killed by it, and 10 million others suffer from its debilitating symptoms. For those who can get treated, 85% will recover, but they'll have to take 4 or more infamously toxic pills for up to 9 months. This regimen is expensive too, and because TB primarily affects people who are already very poor, the pills alone will bankrupt as many as 1 in 3 people undergoing treatment. People who start but can't complete the regimen might develop drug resistance, which then needs thousands of dollars and 30 months to treat. And even then, their chances of survival are halved. As many as 10 million people will be spreading drug-resistant TB by 2050. To top it all off, we only know where 2 in 3 infectious people are. The missing millions can't access or afford testing or treatment, or may not be seeking it because of fear, lack of information, or stigma. These icons stand for some of TB's leading risk factors. In no particular order, these include migration and homelessness, imprisonment, alcoholism, and HIV positivity. Other major drivers include diabetes, overcrowding, and smoking. However, it's undernutrition, the focus of today's presentation, that causes 1 in 5 cases of TB, the most of any risk factor. These are all closely tied to disadvantage and marginalization, characterizing TB as a disease of poverty. Each one also has implications for the immune system. Say your cellmate has TB and coughs on you. The bacteria will start by sitting dormant in your lungs. This condition is called latent TB, and 1 in 3 people on Earth, and perhaps even in this audience, has it. Fortunately, 95% of them will never become infectious because it's so easy for their bodies to fight. It's only when people's immune systems are so weakened by poverty and structural violence that they can no longer contain TB and thus progress to active disease. COVID-19 was catastrophic for the fight against TB. Infection and mortality rates have been steadily decreasing, but for the first time in over a decade actually increased in 2020. Funding has been sliced, fewer people are being tested and treated, and hundreds of thousands of additional lives will be lost. So what happened on the ground? On the right, we have the results of a survey by the Global Fund to Fight AIDS, Tuberculosis, and Malaria, which asked its TB program managers in 32 countries how COVID might have driven people away from testing and treatment between April and September 2020. 83% of them pointed to people's fear of catching COVID at clinics, problems with public transportation, lockdowns that restricted their movement, and the understandable but deadly decision to delay care. There were also massive disruptions on the provider side. From that same survey, we know that almost half of these TB programs were hampered by constant patient handovers, the difficulty of attracting people without their usual range of services, and having to sort through which patients had TB versus COVID. Finally, respondents were asked whether COVID-19 had caused no, moderate, or high levels of disruption. In September 2020, the first time the survey was conducted, 4 in 5 people reported some disruption. Only 13% more programs were back on track when the Global Fund stopped collecting this data just under a year ago. With compromised staff, space, stuff, and systems, to cite the late Paul Farmer, fighting TB in the era of COVID will require new approaches to testing and treatment. Today, I will explain why nutritional support is a promising choice. Undernutrition makes TB worse at every stage of the disease course. First, it makes the vaccine less effective. Then it makes people with latent TB 3 times more likely to develop active TB. There was then a vicious cycle between TB severity and undernutrition during treatment. Undernutrition makes it harder for one's bodies to capitalize on the TB drugs and worsens their side effects. The drugs then are so nauseating that people usually struggle to eat, and they're so expensive that people have less money with which to buy healthy food. TB in turn causes wasting and depresses the immune system further, making it harder to absorb the nutrients that people do ingest. Another threat during treatment is early death. Studies in Malawi, Korea, the Philippines, Brazil, and Taiwan, among others, have found that malnutrition and low body mass increase one's risk of death during TB treatment. Finally, because TB can recur, people with undernourished immune systems will always be vulnerable to it. So the key question now is how we can best leverage food to fight TB in the near future. Two common strategies are using it as an incentive or as an enabler. As an incentive, food could be handed out at clinics as a kind of reward for picking up your medication. When a Russian clinic tried this in 2013 to support patients experiencing homelessness, more than twice as many people were treated without interruption. However, this approach has come under fire for being paternalistic, since it assumes that people can simply be convinced into continuing treatment. But as we know, TB's vicious cycles, poverty, undernutrition, and COVID mean many people stop treatment because of structural obstacles that can't be overcome by just flashing a reward. Instead, we could consider making TB treatment easier, not just more appealing, by leveraging food as an enabler. For example, during COVID, some people are receiving their TB drugs through delivery services. What if we added food to those packages? That would support both their physical and financial well-being, enabling them to continue treatment. Community-based distribution is another promising idea. One program in India did this by using community centers to offer food supplements and individual dietary plans for TB-positive adults. Not only were 16% more patients able to complete treatment, but they also reported better emotional well-being, social functioning, and general health than their underserved counterparts. Nutritional support can protect people living with TB by bypassing many COVID-related obstacles, like fewer TB clinics, doctors, and diagnostic machines. But as millions more people catch COVID every day and armed conflicts rage on, it's important to acknowledge the challenges that this strategy cannot avoid. For example, last month alone, food prices around the world jumped by 13%. It will be difficult to convince already underfunded TB programs to invest in food as prices rise. The next question is whether there will even be food to buy, since conflict and COVID have created massive supply chain disruptions. Finally, because fewer people are visiting clinics for structural reasons, using food as an incentive may not be effective, and because fewer people are being tested, it will be difficult to identify who needs food as an enabler. Fortunately, we may be able to overcome some of these challenges by offering cash transfers to people living with TB and their families. Peer-reviewed studies from around the world show that doing so can have a significant impact on TB burden, in large part because people so often use it to purchase food. Cash transfers can be conditional or unconditional. The former type is like an incentive in that it has eligibility criteria, such as picking up your medicines every week. There might also be spending restrictions, like if food vouchers are only accepted at specific grocery stores. Unconditional cash transfers instead can be given to anyone and spent without supervision, much like an enabler. In this crisis, unconditional cash transfers would be the wiser strategy. There are several points of intervention in TB's vicious cycles with malnutrition, poverty, and COVID, but they vary dramatically on an individual level. What good is a grocery voucher, let alone a conditional one, to someone who can't afford a bus ticket to the clinic or the store, or to people who need books to understand healthy diets or cookware to avoid cheap processed foods? Unless and until we know who is sick, where they are, and what they need, we should use mass unconditional cash transfers to support the nutrition of people with TB. At least 30 people have died of tuberculosis since this presentation began. We've had a vaccine for over 100 years and effective drugs since 1943. It is a moral failing that we didn't protect them. Thank you for your time and attention.